Hi guys, and welcome to our module on protein synthesis inhibitor. In this module, we'll focus on four major protein synthesis inhibitors that you should know about. This includes the likes of the aminoglycosides, chloramphenicol, tetracyclines, and macrolides. Starting with the introduction, what exactly are protein synthesis inhibitors? These are antimicrobial agents that tend to selectively interfere with the synthesis of protein in the bacterium. And one very key point to note about the protein synthesis inhibitors is the fact that most of the protein synthesis inhibitors are bacteriostatic in nature, meaning that they only inhibit the growth of the microorganism. They don't directly kill the microorganism. And then they allow for the immune system to come and clear the microorganism that they've inhibited its growth. The only exception to that rule are the aminoglycosides, which are the only bactericidal protein synthesis inhibitors that is worthy of note. The major protein synthesis inhibitors that are present in pharmacology include the aminoglycosides. We'll talk about that soon. Tetracyclines, then the chloromphenicols, the macrolides, and we have some newer set of drugs like the linezolid and the streptogranins. Right, but when we're talking about the protein synthesis inhibitors, we tend to focus on the first four, and that is what we'll talk about in this particular module. So for us to talk about protein synthesis inhibitors, it's important for us to review our biochemistry on the topic of translation of protein synthesis. Now, when we talk about protein synthesis, the first thing to remember is that the site of protein synthesis in all cells is found at the ribosome. The ribosome in the human cell differs from ribosome found in the bacterial cell. The major difference is usually in the composition of the ribosome. The ribosome in the human cell is made up of two subunits, and each of the subunits are formed by 40S and a 60S structure, whereas the one in the bacterium is usually cut in or usually formed by a 30S and 50S. And this informs us on the reason why we tend to have selective toxicity for protein synthesis inhibitors. Remember that protein synthesis inhibitors selectively destroy or selectively interfere with protein synthesis on the bacterial ribosome. The reason is because the bacterial ribosome is different from what we see in the human ribosome, and as a result, the protein synthesis inhibitors that we're talking about, they only act on the 50S and 30S subunit of ribosomes. They don't act on 40S and 60S, which is what we see in the human cell. The process of protein synthesis, I tend to remember it using four major steps. This is not necessarily something that it's been spoken about in biochemistry, but it's just a way for me to remember it and to help us out when talking about the protein synthesis inhibitors very soon. So what are these four steps? They include initiation. Right, initiation is the starting point of protein synthesis inhibitors, of protein synthesis rather in a bacterial cell. Second is elongation. And after elongation, we have transpeptidation, which is the third step. Usually in biochemistry, they talk about transpeptidation as termination, not necessarily transpeptidation, but just for the sake of explanation, I'll call this third step transpeptidation. And the fourth step here is translocation. I'll talk about what each of these particular steps mean. Now let's talk about them one by one. First of all, each of these steps tend to occur within different points on the ribosome. Ribosomes are divided into three major sites. We have the A site, also called the acceptor site. We have the P site, called the peptidation site, and then we have the E site, called the exit site. Now let's start with the first step, initiation. For protein synthesis to start or transition to start, we need a tRNA carrying an amino acid, and that tRNA must contain a starting codon. The tRNA in this case tends to carry the amino acid methionine. As you look at this particular screen that talks about initiation of translation, you notice that the first tRNA carrying the first amino acid tends to bind to the P site of the ribosome. And this is very key to note. So the first tRNA binds on the P site, and once it binds on the P site, it drops the first amino acid. In this case, the amino acid is methionine. What happens after that is elongation. Elongation is the second step. What happens in elongation is that we tend to see a second tRNA carrying another amino acid now moving in towards the ribosome. And this second tRNA tends to bind at the A site. So you can see it binding at the A site here. And what happens is that once you have this two tRNAs found on P site and the A site, we have the amino acids being carried by either of them uniting together or connecting together through a process called transpeptidation. That's the third step. So transpeptidation is the union of the amino acid being carried by the tRNAs found at the P site and at the A site. And once you have that transpeptidation occurring, each of the tRNAs become free, all right, and you see them eventually moving from the P site to the E site and from the A site to the P site. So the initial tRNA on the P site, after it has allowed its amino acids to unite with the amino acid of the tRNA on the A site, that particular tRNA on the P site will translocate towards the E site, which is the X site, and then the one on the A site will translocate towards the P site. And as a result, you have the termination of the process occurring at this point. Well, that is usually it's usually important to know it's a continuous process. We have more tRNAs coming in, going from the A side to the P side to the E side, and then they are dropping amino acids. Each of these amino acids are going to be joined together through a process called transpeptidation. So in a nutshell, the entire process of protein synthesis or translation involves initiation, elongation, transpeptidation, which occurs at the P site, and then translocation, which is the movement of tRNAs from the P site towards the E side, or from the A side towards the P side. And why I broke this down in this particular step is because of the fact that the four drugs we'll talk about, the four drugs that are the major protein synthesis inhibitors, tend to act either with initiation, elongation, transpeptidation, or translocation. Let's start with aminoglycosides. Aminoglycosides, in terms of chemistry, are antibiotics that have been derived from a particular fungi called Streptomyces species. This amino acids, in terms of its chemistry, tends to consist of two or more amino sugars, usually joined by a glycosidic linkage to a polybasic amino hexose nucleus structure. The polybasic amino hexose nucleus structure tends to be either a streptidine or deoxystreptamine. So how we talk about the chemistry is simple. We have two amino sugars, so one here, another here, joined together with a polybasic amino hexose nucleus. In this case, you can see the picture showing us a 2-deoxystreptamine, which is the polybasic amino hexose nucleus. It could also be a streptidine. Streptidine could also be what unites the two amino sugars together. The reason why we call it aminoglycoside is because we have the amino portion being the two amino sugars, and then the glycoside being the glycosidic linkage of the amino sugar with the polybasic amino hexose nucleus. And that's the reason why we call them aminoglycosides. What are the examples of aminoglycosides that we should know about? They include the drugs streptomycin, gentamicin, tobramycin, amikacin, netilmycin, kanamycin, neomycin, which is very common, and cisomycin. What you notice about each of these drugs is that they have a suffix that tends to unite them. They're either ending with a mycin or a mycin. So MICIN. So that's a mycin. Or you could see them ending with a mycin, MYCIN. So once you see a drug that ends with either of these suffixes, you're thinking about aminoglycoside. Let's talk quickly about the mechanism of actions of our aminoglycosides. First thing to note is that aminoglycosides are antibiotics that are only effective against gram-negative aerobes. The reason for this is very simple. So first of all, for the aminoglycosides to act on any microorganism, on the gram-negative microbes, they would need to enter into the cytoplasm of that microbe. Gram-negative, remember, tend to have two membranes. They have an outer membrane and an inner membrane. And in between those two membranes is a periplasmic space that tends to separate them. So for the aminoglycoside to enter into the cytoplasm of a gram-negative microorganism, it would need to first go from the outer membrane, so this is the outer membrane here, into the periplasmic space. And it needs to do this through a process called passive diffusion. So it goes from the outer membrane to the inner membrane through passive diffusion. Then for it to go from the inner membrane into the, for it to go from the periplasmic space rather into the inner membrane, this is the inner membrane here, it needs to enter through an active transport. So active transportation is how it goes from the periplasmic space into the inner membrane. Once it is making that cross from the periplasmic space into the inner membrane, it makes use of oxygen, glucose alongside ATP. And this is the reason why we only see aminoglycosides being effective against gram-negative errors. Gram-negative because it is going to be passing through the outer membrane and then inner membrane, and we only see two membranes in a gram-negative bacterium. Secondly, gram-negative aerobes because of the fact that for it to go from the periplasmic space into the inner membrane space or into the cytoplasm, it makes use of an active transport. and that active transport requires oxygen and glucose to form ATP for it to work. So without oxygen present, like what we see in anaerobes, uh, aminoglycosides will not be able to enter into the cells, and they will not be able to act on the ribosomes in preventing protein synthesis. Second thing to note about the aminoglycosides is the fact that they are bactericidal. They are the only bactericidal protein synthesis inhibitors that you need to know about. And how they tend to do their work in terms of mechanism of action is that they act on both the 50 and 30, and the 30S subunits of the bacterial ribosome. So this is very key to note. As you see for the other drugs are usually restricted to either the 30S or the 50S, but not both. But aminoglycosides has activities on both of these subunits of ribosome. Aminoglycosides tend to have their work on the initiation step, the very first step of protein synthesis in the bacterial cell. And in terms of what it does on the 30S, it is inhibiting, irreversibly inhibiting initiation of protein synthesis at the 30S subunit. At the 50S subunit, what it does is that it tends to block translocation. So it has activity on translocation and initiation, but the major focus is on initiation. It tends to block initiation. It blocks that very first step of the movement of the tRNA towards the P site, and then the release of the first amino acid to initiate protein synthesis. Because it is blocking these two steps, blocking initiation and translocation, what it eventually will lead to is what we call a misreading of the mRNA. And this misreading of the mRNA will lead to the eventual cell death of the bacterium. And this is the reason why we say that aminoglycosides are bactericidal, because of the ability to cause cell death due to misreading of the mRNA as a result of their action on inhibition, or initiation and translocation. One very key thing to note about aminoglycosides is that we can combine them together with beta-lactam. They are very effective drugs when we combine them with beta-lactam. Remember that combination of beta-lactams together with aminoglycosides will give us a synergistic effect, and that is a very powerful effect. But because both drugs tend to be bactericidal, so they will lead to an eventual terminal death of the bacterium that we're trying to eradicate. This is the image of the aminoglycosides and where they tend to act on. You can see that aminoglycosides will block initiation, as you can see, and they also tend to block a bit of translocation here. But the major action is usually in the blockage of initiation, as you can see in this image. Let's talk about the pharmacokinetics of aminoglycosides. That is the ADME, administration, absorption, the distribution, and metabolism and excretion of aminoglycosides. Starting with the administration, it's very important to note that all aminoglycosides are administered enterally. So they're either given IV, SC, or IM, usually IV. The exception to this rule tends to be neomycin and kanamycin. The reason for this is very simple. Now, absorption of amino dioxide is very poor when given orally or rectally. Usually, we usually say that about 1% or even less than 1% of aminoglycosides are absorbed orally. Um, as a result, we cannot necessarily be giving them orally because of that poor absorption. So we prefer giving them IV directly into the systemic circulation, or IM or SC parenterally. And the reason for this poor absorption is because of their highly polar cations, and as a result, the more polar you are, the likely or the less likely you are going to be absorbed into the bloodstream. The other drugs that are the exception, neomycin and kanamycin, the reason why we can give them orally is not because we want them to be absorbed, or not because they are absorbed um, into the bloodstream of the GIT better than the rest, but because when we are giving neomycin or kanamycin, we want them to act only at the GIT. We don't want them to move away from the GIT. And they are usually drugs that we give when we are doing bowel preparation. We want to clear the entire GIT or clear infection in the GIT. We give neomycin to clear the entire GIT and make it very sterile, because the neomycin there will just act on the GIT and not move or be absorbed into the bloodstream automatically from there. Once aminoglycosides enter into the bloodstream, it gets distributed to various organs. The volume of distribution of aminoglycoside is within 20%, and this distribution tends to vary across board. So usually distribution to the CNS is relatively poor. Remember that aminoglycosides are very polar structures, and as a result, the excess polarity would be um, a hindrance for distribution to the CNS. Unlike the CNS, the kidneys, the skeletal muscle, and the inner ear tend to have rich distribution of aminoglycosides. And then one more thing to note is that this distribution tends to be orchestrated by the plasma protein albumin. The only aminoglycoside that does not bind to albumin during this distribution is streptomycin. The elimination of amyloid glycoside is also straightforward. It is excreted unchanged in the kidneys. Right? Renal excretion is usually through glomerular filtration and is not really broken down in the liver for it to be excreted. The half-life of amyloid glycoside is within 2 to 3 hours. Amyloid are effective against gram-negative errors, like I talked about. The reason is very simple, because of the fact that gram-negative organisms tend to have both an outer and inner membrane and a periplasmic space. This is usually how the amyloid tend to move towards the cytoplasm of a bacterium cell. And usually gram-negatives that have that particular configuration. Aside this, the aerobes tend to make use of oxygen for them to grow, and oxygen is needed for the amyloid to enter into the cytoplasm of the gram-negative, usually when it's crossing from the periplasmic space into the inner, into the through the inner cell membrane into the cytoplasm. It makes use of active transport that would make use of ATP gotten from oxygen and glucose. There are few aminoglycosides that are active against Pseudomonas aeruginosa infection, and these include drugs like tobramycin, gentamicin, amikacin, metilmycin, and cecomycin. And these are very important questions they can ask you in your MCQ. What are the indications for using aminoglycosides? They include subacute bacterial endocarditis, tuberculosis. So usually, streptomycin was the drug of choice of tuberculosis at a certain point in history, but it is not really a drug of choice any longer. We still use some of the aminoglycosides like amikacin as a secondary choice in treating tuberculosis that is resistant to our first-line drugs. Then we have plague, the brucellosis, tularemia, osteomyelitis, pneumonia, urinary tract infection, and then bowel surgery prophylaxis. Remember that for bowel surgery prophylaxis, we make use of drugs like neomycin because of its ability to stay within the GIT and clear the entire GIT of bacterium before a surgery is done. What are the adverse effects of aminoglycosides? Remember that aminoglycosides are well distributed to 3 major organs. This includes the kidneys, the skeletal muscles, and the inner ear. As a result, we tend to see a lot of adverse effects in these 3 sites. So for the kidneys, we see adverse effect of nephrotoxicity because of its rich distribution to the kidneys. For the inner ear, we see the adverse effect of ototoxicity and vestibulotoxicity, and this will present with symptoms like tinnitus, ataxia, and vertigo. Remember that the inner ear is involved in 2 major functions, or ability to hear, ability to perceive audition or sound, and as a result also the ability to maintain balance. So if balance is affected, you have ataxia or vertigo. If hearing is affected, you can have tinnitus as well occurring. Aside the inner ear and the kidneys, the skeletal muscle is also one very important structure that has rich distribution of aminoglycosides towards it. And the side effect we see for the skeletal muscle is neuromuscular blockage. So the person is going to be having a lot of flaccid paralysis when there's excess amino acid being used. Amino acids could also be distributed to the placenta, through the placenta to the baby in a pregnant woman, and it could be highly teratogenic to the child. So it's not usually prescribed for pregnant women. Some of the contraindications for aminoglycosides include myasthenia gravis. Remember, it tends to have an adverse effect on the skeletal muscle, so it could worsen myasthenia gravis in someone that already has it. Botulism. Botulism is when there's a poison, botulinum toxin, that is causing flaccid paralysis in an individual. So you don't want to worsen their flaccid paralysis by giving them aminoglycoside. Pregnancy is also a contraindication. Pregnant women are not going to be prescribed aminoglycoside because of its teratogenic effect. And then finally, renal failure, because of the nephrotoxicity that we see for aminoglycoside, we would not want to prescribe it to someone that has an underlying renal failure. What are the mechanisms of resistance to aminoglycoside? So some of the bacterium that resist aminoglycosides could do this by either producing an enzyme that will inactivate the drug. So these enzymes either do that by acetylating the aminoglycoside, or phosphorylating the aminoglycosides, or adenylating the aminoglycosides. Are all different process steps or metabolism that the bacterium could use in inactivating the aminoglycoside using an enzyme. Another way in which bacterium could resist the aminoglycoside is by decreasing accumulation through the failure of permeation of the antibiotic. Remember that aminoglycosides must first of all go through different means of transportation to enter into the cytoplasm. From the outer membrane to the periplasmic space, it makes use of porins through passive diffusion. So you could have the bacterium altering the porins and eventually reducing the entry of the aminoglycoside into the periplasmic space. You could also have them altering the particular active transporter that it uses when it's moving from the periplasmic space into the cytoplasm. This is one way in which the effect of aminoglycosides could be resisted by a bacterium. The last mechanism could be alteration of the target site. Target site in this case is the ribosome. So a bacterium could alter its ribosome, maybe making it to be maybe 40S, 50S, changing the configuration of the ribosome, and then making the aminoglycoside not to be able to bind on the ribosome and do its work of inhibiting initiation and translocation. So chlorphenicol is an antibiotic gotten from the fungi Streptomyces venezuela. In terms of its chemistry, it is described as a nitrobenzene moiety that is derived from a dichloroacetic acid. The dichloroacetic acid is found in its chemistry. As you can see in the chemistry below, the dichloroacetic acid is shown directly down here as nitrobenzene ring as well. And this tends to confer the antibacterial property of the chlorphenicol to it. Its structure is described as a yellowish white crystalline solid that is very bitter in taste. So when you put it in your mouth, you should expect to have very nasty taste being felt when taking chlorphenicol. There are two examples of chlorphenicol you should know about: this chlorphenicol succinate and this chlorphenicol palmitate. Either of those drugs are usually given orally. We hardly give chlorphenicol IV, but we tend to get oral drugs or even giving topical drugs alongside. The mechanism of action of chlorphenicol is straightforward. As a protein synthase inhibitor is going to be acting on the ribosome. The particular ribosome it works on is the 50S ribosome. And in terms of its activity, chlorphenicol is involved in inhibiting the transpeptidation step of protein synthesis. It acts during elongation and it prevents transpeptidation. And this is how it tends to perform its work. And if you look at the picture directly below, you notice that the point where aminoglycosides will do their activity is by preventing the union of the amino acid on the A sides from combining with the amino acids on the P side to form a peptide bond. That's the ability of it inhibiting transpeptidation. One very important thing to note is that the chlorphenicols tend to be bacteriostatic as compared to what we see for aminoglycosides, which are usually bactericidal. Pharmacokinetics of chlorphenicol is straightforward. It's a drug that can be given orally, IV, topically. Usually, we don't give it IV anymore, but we can still give it orally and topically. It's a drug that is also well absorbed uh, through the GIT, so it has rapid and complete absorption through the GIT. To contrast to what we see in terms of aminoglycoside, which has very low, poor absorption. The two forms of of chlorphenicols are usually given orally, and first one, which is chlorphenicol succinate, is usually an active drug that does not really require any further activation. But chlorphenicol palmitate is usually a prodrug that will require activation for it to do its work. And the activation is usually done by hydrolysis, which converts the drug to its active form before it gets absorbed into the GIT. So chlorphenicol tends to enjoy very good distribution across board. It tends to be about 50-60% bound to plasma protein and is widely distributed to the CNS, to the placenta, and to the mammary glands. And this would influence some of the side effects that we see for chlorphenicol. The elimination of chlorphenicol is within the liver and the kidneys. It is metabolized first in the liver during phase 2 reaction called glucuronidation, and then it is excreted in the kidney with few of it being unchanged during excretion. The half-life of chlorphenicol is within 3 to 5 hours. Chlorphenicol is a broad-spectrum antibiotic that tend to act on a number of different bacterium, including Salmonella typhi, Haemophilus influenza, Neisseria meningitidis, Streptococcus pneumonia, Rickettsia, Brucellosis, and then Bacteroides viridalis. One very important thing to note about chlorphenicol is its activity against anaerobic infection. So that's very key to note. One reason why you can prescribe a chlorphenicol to a patient is because of them having anaerobic infection like Bacteroides viridalis infection. What are the indications for using chlorphenicol? They include rickettsia, brucellosis, pyogenic meningitis, anaerobic infection, which I said is very key to remember, endophthalmitis, otitis externa, and then typhoid fever. Side effects of chlorphenicol are very key to know. The reason why we need to even know the side effects is because of the fact that clonfenicol is not really a common drug we prescribe anymore, and the reason is because of the side effects. The side effects are too grave, um, and they tend to outweigh some of the benefits. So most people prefer to use other drugs that are safe compared to clonfenicol. So side effects of clonfenicol include one, the type A, B, C, and D adverse drug reaction. We talked about that in the modes under adverse drug reaction, and that was under pharmacodynamics too. Then aplastic anemia, usually in children, tends to occur. Gray baby syndrome, which I'll show you a picture of, is also a side effect. The reason why they tend to have gray baby syndrome is because in a child or in a baby, the liver is not fully matured, and that particular phase two or required for the metabolism of clonfenicol will not exist because the enzyme there has not been fully developed or fully formed in a child. So as a result, that child will have very few clonfenicol being metabolized, and we have an accumulation of called in the child's bloodstream, and that can lead to the symptom called Cray-Baby syndrome. Superinfection could also be a cause. Clonfenicol could be a cause of pseudomembranous colitis, as we talked about. Gastrointestinal upset because it can be taken orally, and then you could have hypersensitivity reactions like rash, fever, and angioedema that's from using clonfenicol. What are the contraindications of clonfenicol? One is infancy. We don't give it to the child because of Cray-Baby syndrome and aplastic anemia. In children as well, we don't give it because of their not fully developed liver and liver enzymes, and as a result, we want to avoid having them having aplastic anemia or Berry syndrome. Pregnancy could also be a contraindication because it could be teratogenic to the child. It could lead to aplastic anemia in the child still present within the womb. Kidney failure and liver failure as well, because if there's a kidney failure and liver failure, the excretion and metabolism of clonfenicol will not be possible, and that can lead to more adverse effects being seen in the individual. So how do various bacteria resist clonfenicol? They do so by the production of enzymes that would inactivate the clonfenicol. These enzymes are usually plasma encoded acetyl transferase, so they tend to perform acetylation of clonfenicol. As a result, they render the drug to be inactive.
The next antibiotic on the list is tetracycline. These are derivatives of polycyclic naphthalene carboxamide structure. In terms of appearance, they tend to be crystalline form, faintly yellowish, odorless, and then slightly bitter. For anyone that has ever taken tetracycline, you know that one striking thing about it is its bitter taste. Just like every other antibiotics, it is obtained from a fungi. Particular fungi where we get tetracyclines tend to be the Streptomyces euromycin and Streptomyces eurofascin. This is the structure of tetracycline down below. You can see how it has a quadruple ring, hence the name tetracycline. It's called tetracycline because the chemical structure is made up of four cyclical naphthalene rings, as you can see in the image down below. What are the examples of tetracyclines? They include chlorotetracycline, oxytetracycline, tetracycline itself, demiclocycline, the metacycline, doxycycline, and minocycline. And what you need to note from this slide is that the potency of the different examples of tetracycline tends to increase as we go down the example. So the most potent tetracycline is the minocycline. The least potent tetracycline is chlorotetracycline. One thing to also note is that minocycline is one of the tetracyclines that we commonly see in use in dental procedure and dentistry. For medical use, we typically see doxycycline being used commonly compared to others. What's the mechanism of action of tetracycline? As a protein synthase inhibitor, it's a drug that will be acting on the ribosomes. The particular subunit of ribosomes that it is notorious for acting on is the 30S subunit. And during the process of protein synthesis, during the process of translation, the step in which it tends to block by acting on the 30S subunit of ribosome is the step of extension. So it prevents further elongation or extension of the amino acids that are forming the peptide. And as a result, it leads to the inhibition of protein synthesis there. So, tetracyclines alongside the other antibiotics, the other protein synthesis inhibitors, like we discussed already, are bacteriostatic. This is unlike what we see for ammonic glycosides that are bactericidal. Let's talk about the pharmacokinetics of tetracyclines. First of all, starting with administration, we prefer to give tetracyclines orally, although if warranted, we could also give it IV, but the common way or route of administration for tetracyclines tend to be oral. Then, in terms of the absorption, because we give it orally, it means that it must have a very good absorption. There's a very unique property about the absorption of tetracyclines, and that is in fact that we prefer to give tetracyclines on an empty stomach or in a fasting state. The reason for this is simple. When giving tetracyclines, because of its drug-to-drug interaction with many substances found in food, um, when we give it with with food, we tend to have it binding together with substances like ions, usually divalent ions or trivalent ions like calcium, aluminium, magnesium, and iron. And as a result, once tetracycline binds to these divalent or trivalent ions, they would get excreted out through the GIT. So the drug will not get absorbed into the bloodstream. Instead, it will be excreted out into the GIT. So as a result, we prefer to give it on empty stomach. We avoid using tetracyclines together with foods like milk, or drugs like ion supplements, antacids, or any food containing divalent cations. So cations like calcium, like aluminum, like magnesium, like iron, like I mentioned, these are divalent and trivalent cations. And these are substances that contain these cations are substances that we would avoid um, prescribing or using together concurrently with tetracyclines. Moving on to distribution of tetracyclines, in terms of the volume of distribution, which is the measure of distribution of tetracycline, the distribution is relatively larger when compared to the body water, so it tends to distribute to a number of organs. The exception of the CNS, it has very poor distribution to the CNS. Some of the organs that is notorious for keeping or holding tetracyclines in terms of distribution includes the liver, the placenta, and the breast milk. And it's important to keep this in mind because when you're talking about side effects, some of these organs that have very large distribution of tetracyclines, very good or rich distribution of tetracyclines, will tend to present with side effects when we get to the section of adverse effects. For example, if we have large amount of tetracyclines going to the liver, this could be one of the reasons why tetracyclines could be hepatotoxic. It would also distribute to the placenta, to the bones, and then to the breast milk. So you can see bone problems alongside side effects of it being teratogenic to children because of its distribution to the placenta and the breast milk. How is tetracycline eliminated from the body? Excretion of tetracycline is purely by the kidneys, but also a bit of it is excreted through feces, through fecal matter. Usually, doxycycline is the one notorious for being excreted through the GIT, through bile and into the intestine. But the rest of the tetracyclines are excreted primarily through the kidneys. As a result, whenever we have renal failure, we should be cautious of the dose of tetracycline we are giving to a patient. Right? Doxycycline is the only tetracycline that is not contraindicated in patient with renal failure. Every other one tends to be contraindicated, or we need to watch those because of their excreted through the kidneys. Doxycycline is the major tetracycline excreted through fecal matter, and as a result, we tend to watch for um, the dose of doxycycline when we have a liver pathology. What's the bacterial spectrum of tetracycline? It's a broad spectrum antibiotics, so it is used in treating a lot of different bacterial infection. So bacterium like Neisseria meningitidis, Vibrio cholerae, Asclepias tularensis, Cutibacterium acne, and then community-acquired MRSA are very popularly treated with tetracycline. When we talk about the use of recycling in the modern world, we talk about its use particularly for um, what we call intracellular organisms. So organisms or bacteria that have to thrive by being intracellular. This is usually the reason why we tend to prescribe tetracyclines. So organisms like Rickettsia, like Chlamydia, and a plasma are intracellular organisms. Alongside this, we also use tetracyclines for organisms, bacteria that lack cell wall. So organisms like Mycoplasma pneumoniae, and uroplasma are organisms that we use tetracycline in treatment alongside the other. So most of the other organisms that I mentioned, though tetracyclines could cover for them, it's broad spectrum. In terms of the modern world, we prefer using safer antibiotics like penicillins and cephalosporins, and we just save tetracyclines for the more difficult ones, the more difficult bacterium like the ones that lack a cell wall and the ones that are found intracellularly. So what are the indications for the use of tetracycline? Infections like hypogranuloma, venereum, trachoma. Trachoma is usually caused by chlamydia. So it's a chlamydia-based infection, rickettsia infection, mycoplasma pneumoniae, chlamydia itself, so chlamydia infection, which is the sexually transmitted form. We have other forms of chlamydia infections like trachoma and hypogranuloma, venereum. Well, most of these infections are caused by chlamydia. Remember, chlamydia is an intracellular bacterium. Hence the reason why it's an indication for the use of tetracycline. Other uses would be non-specific urethritis, gonorrhea. This is also caused by chlamydia, and then malaria. We could treat malaria by giving tetracycline. Usually, we tend to give doxycycline, usually as a form of treatment for people that are traveling from a non-endemic area to an endemic area. It's more of a prophylactic treatment, not necessarily um, treatment for curing or clearing the malaria. For clearing malaria, we have specific drugs for that. But for people that are traveling from maybe the US to Nigeria and need to be on prophylactic anti-malaria, we can give them cycline. It's a indication that we could use. What are the adverse effects of tetracycline? These adverse effects purely by the fact that tetracyclines tend to distribute to a number of organs. Some of the side effects include gastrointestinal upset. It's taken orally, so it will cause some form of gastrointestinal irritation. It could lead to gastric burning and stress. It could lead to abdominal discomfort and nausea and vomiting as well, particularly because it distributes largely to the liver. It could also be a source of hepatotoxicity in excess, especially when for someone that has liver problems. This person could come down with hepatotoxicity because of its deposition in the bones and the teeth. There's just like things could lead to yellowish to brownish discoloration of the teeth in teens, usually from 7 years to about 12 years. It could also present with cases of photosensitivities. People could have in rash. I think me personally experienced this while growing up. The use of tetracycline as a child, I started having photosensitivity and I had to stop the drug. And then run out toxicity for most of the drugs, most of the tetracyclines that tend to be excreted through the kidneys. Other adverse effects that are not so common includes Fanconi's syndrome and pseudotumor cerebri. These are very rare side effects. On the screen below, you could see an example of one of the side effects of tetracycline, which is very notorious. The fact that it could lead to dental hyperplasia. One of the things that we note about tetracyclines is that we tend to not give it to children because of the fact that it could lead to poor growth of their bones and it will lead to aside dental hyperplasia, bone hyperplasia. So we say that tetracyclines tend to be contraindicated in a particular group of age, particular age group. So contraindications, like I said, includes children below 8 years, pregnant women because of the fact that it could be teratogenic, kidney failures, particularly most of the tetracyclines aside doxycycline is contraindicated. Doxycycline is also given to children because of its very reduced side effects. It is a potent drug but has very fewer side effects. Breastfeeding mothers are also contraindicated, and then hepatic failure, particularly for doxycycline, is also a contraindication for use of tetracyclines. What's the mechanism by which bacteria could resist tetracycline? It's just one particular mechanism, and that is in the decrease of the accumulation of the drug. For tetracyclines to work, they need to enter into the cytoplasm of the bacterium, act at the ribosome, 30S subunit of ribosome. So some bacterium devise different ways to evade the entry of tetracycline or reduce the accumulation of tetracycline within their cytoplasm. And one way is through the distribution of what we call the plasmid encoded transport pump. This pump just tends to push out tetracycline once it enters into the cytoplasm of the bacteria. So it pushes it out, reducing its concentration and reducing its effect on the bacteria. The last antibiotic we'll talk about in this session will be the macrolides. These are drugs that chemically described as consisting of a macrocyclical lactone ring, emphasis on the lactone ring, which tends to be attached to the sugar molecule. As you can see on the screen below, this particular structure has this is the structure of a lactone ring, and you can see it's being connected to multiple sugar molecules. Because an antibiotic, it will also be obtained from external sources. We tend to get macrolides from the fungi Streptomyces erythroides. And as you notice, most of the protein synthesis inhibitors are all antibiotics gotten from one fungi or the other. What are the macrolides we use? We have three major macrolides we use. This includes erythromycin, which is very commonly used, clarithromycin, and then azithromycin. These are usually naturally occurring macrolides. We have some artificially made macrolides that are not commonly used, with drugs like spiramycin, gentamicin, medicamycin. We have some synthetically formed ones and others. This is not really a point of focus because of when we talk about macros, we talk about the popular three, big three, and we just focus on those three. So in this particular module, when I'm talking about macros, I just pay attention to those first three that are on the screen. What's the mechanism of action of macrolides? They tend to act at the ribosome in enacting their inhibition of protein synthesis. Particularly, they act on the 50S ribosome. If you are to break down the 50S microarray, the parts of the 50S ribosomal subunit that they act on is what we call the 23S. So they act on the 23S section of the 50S subunit of ribosome. And what they do is that they tend to block the process of translocation. Remember that aminoglycosides block the process of initiation. The drugs graphenicol block the process of transpeptidation. Tetracyclines, which we just talked about, blocks the process of extension or elongation. And finally, macrolides blocks the process of translocation. Each of them tends to act on different subunits. Aminoglycosides are acting both on 30 and 50. Clanphenicol and macrolides act particularly on the 50S, whereas tetracyclines act on the 30S. Macrolides tend to be bacteriostatic, similar to what we see for the other three antibiotics we talked about, clanphenicol and tetracyclines. Um, it could be bactericidal, but usually tends to be bactericidal at higher concentration, similar to what we see for the aminoglycosides. Let's talk about the pharmacokinetics of macrolides. It could be given orally or IV. And in terms of absorption, erythromycin tends to have an incomplete absorption when given orally. This is different from the other two macrolides, clarithromycin and azithromycin, which have very rapid and complete absorption given orally. Food tends to delay the absorption of erythromycin and azithromycin, but it affects more of erythromycin. At the end of the day, azithromycin is absorbed better off compared to erythromycin. Food doesn't affect the absorption of erythromycin. That's the distinction in terms of absorption between the three macrolides. In terms of distribution, all three macrolides are well distributed. They are distributed to almost all the tissues except the CNS. In terms of their protein binding, it also tends to differ. Erythromycin binds largely to protein, about 70-80% of it will bind to plasma proteins, followed by azithromycin, which is about 41%, and then clarithromycin, about 40 to 70%. In terms of the elimination of each of these macrolides, azithromycin and clarithromycin tends to undergo hepatic metabolism before they are eliminated. And azithromycin in particular is eliminated through the hepatic route. So after it has been metabolized by the liver, it is excreted out of the body through bile. Erythromycin and clarithromycin, whereas are excreted out of the body through the renal route, through the kidneys. And also, one very important distinction between the three is in terms of their half-life. Erythromycin has a half-life of about 1.6 hours, clarity is about 3 to 9 hours, and then azithromycin has the longest half-life of about 3 days. Let's talk quickly about the bacterial spectrum. Erythromycin and the other macrolides have very broad spectrum of activity. Erythromycin typically acts on gram-positive, gram-negative organisms alongside intracellular organisms. So most of those intracellular organisms that we use tetracyclines for treating could also use erythromycin as an alternative. As a result, we see most of the indications for tetracycline also being indications for erythromycin. One popular thing to note about erythromycin and the other macrolides is the fact that they tend to be substitute drugs for um, conditions that we typically use penicillins and cephalosporins in treating. That's because the spectrum of bacterial activity is very broad to the point in which it can cover for almost all organisms that the beta lactams are covering for. Erythromycin also has very broad spectrum activity. Gram-positive organisms, gram-negative organisms, alongside intracellular organisms like Mycoplasma pneumoniae and Legionella hemophilia. Finally, azithromycin has also very similar spectrum of activity with the addition of Chlamydia trachomatis as compared to clarithromycin. Those are the indications for macrolide use. They include atypical pneumonia. Atypical pneumonia usually is caused by some of those intracellular organisms like Mycoplasma. Syphilis could also be an indication. Although for syphilis, we prefer to use beta-lactam, particularly penicillins. But if the penicillins are not working, or there's a resistance, or there's a reaction to penicillin, now an alternative drug would be a macrolide. Typhoid fever, typically we use azithromycin to treat that. Whooping cough, some sexually transmitted disease, we could use the macrolide as a cover drug. Upper respiratory tract infection, we use drugs like erythromycin and azithromycin to cover for that. Gynecological infections, skin and soft tissue infections, ulcer. So in treating ulcer, we usually use triple therapy, a combination of proton pump inhibitors rather, alongside drugs like clarithromycin and metronidazole. We could substitute the clarithromycin um, for a beta lactam like amoxicillin. But if there's no amoxicillin, we prefer to use clarithromycin as the cover in the triple therapy. And then diphtheria could also be an indication for the use of macrolide. What are the adverse effects of macrolides? This includes gastrointestinal upset because we give them orally, so they could irritate GIT, lead to motility problems, causing diarrhea, constipation, nausea, and vomiting. Very importantly, macrolides are notorious for causing what they call a QT interval prolongation, and as a result, it could lead to arrhythmias. Along another very important adverse effect of macrolide is the cause of acute cholestatic hepatitis. Yeah, some of these macrolides are broken down in the liver, and also some of them are excreted in the liver, and they could lead to hepatitis as a result. Eosinophilia is also a common side effect of macrolide, although rare. And then someone could have reactions to the drugs, hypersensitivity reactions that could present as rash, and typically in infants, giving macrolides could increase the risk of hypertrophic pyloric stenosis, usually for infants that are up to about 6 weeks of age. One way to remember the side effects of macrolides is by remembering the mnemonic macro. And the macro there stands for M, motility receptor stimulation. A there stands for allergies, which will include rash and eosinophilia. Cholestasis, which is acute cholestatic hepatitis. The rash as well, although that's already covered for by the allergies. And then ototoxicity, although I didn't mention that in my slide, but macrolides could also present with ototoxicity, which could affect the um, uh, hearing of the individual, leading to hearing impairment. And that concludes our module on protein synthesis inhibitors.